Thank you all so much for joining us today. It's a pleasure to welcome you to our CareDx Symposium at CIOT, Improved Precision with a Multi-Modality Approach. Well, we are so sad that we can't be at Weston together, but are already amazed by the massive leaps in science this year. My name is Nikhil Agrawal, and I am our Medical Director for Kidney Transplant here at CareDx. CareDx is your partner in transplant care, and our vision is to be the leading partner for transplant patients and the transplant ecosystem. We are committed to improving transplant patient outcomes by providing innovative and intelligent solutions throughout the entire patient journey. That's why front of mind for us is the patient, and why you see our patients highlighted across the journey today. The patient journey at CareDx spans the entire transplant journey, from diagnosis to dialysis to referral, evaluation, waitlist, offer, and many post-transplant care. We aim to bring the best services and products to all of our patients throughout your journey. Innovation is what we all aim to do, and why we all want to be on the cutting edge of transplantation. This symposium today aims to highlight some amazing work going on in the clinical research space and to think through where the road may take us at CareDx. While we have made significant strides in advancing our science, the excitement is not just in our multimodality markers like AlloSure, AlloMap, and soon to be kidney care in immediate term, but also considering where innovation is needed in the space. Looking forward, where can we go from here? Tools like UroMap, HistoMap, and AlloID that might fill the gaps for critical patients. When we talk about transplant, we aim to mitigate, quantify, and minimize risk. For post-transplant, what can you use as a standard of care? What can move the needle in terms of outcomes? Most importantly, with multiple touch points across the patient journey, what will make the world a better place, make transplant better, stronger, and make lives of healthcare professionals a little easier? The amount of groundbreaking evidence has exploded. Now that the value molecular tools bring has been accepted as a standard of care, where can we go further? How do we embed tools with care pathways? When we talk about tools that we think about, how do we move from observation to intervention? At CareDx, we are proud to support continuous clinical development through large multi-center studies, a robust IIT program, and grant support with over 40 transplant investigators. Much like the incredible research being done across this space, we think about where the future is. We are proud to have a number of multi-center clinical studies underway and have had some exciting publications occur this year. So here to share some of that great readouts for us are some incredible speakers. First of all, Dr. Amishi Desai, a transplant nephrologist and medical director of kidney and pancreas transplantation and division chief of transplant nephrology at Loyola University. Then Dr. Abdul Reza Haririan, who's a transplant nephrologist and attending physician on transplant medicine and general nephrology services at the University of Maryland Medical Center. Dr. Neeraj Singh, a transplant nephrologist and the medical director for kidney and pancreas transplantation at John C. McDonald Regional Transplant Center, in addition to serving as an associate professor of medicine at LSU Health Science, Shreveport. And last but not the least, Dr. Deborah Levine, who is the medical director of pulmonary hypertension, medical director of lung transplantation, and professor of clinical medicine at University of Texas Health Science Center in San Antonio. With that, it's my great pleasure to pass the mic to Dr. Desai, who will now share a bit about the Admiral study with us. Dr. Desai, over to you.
Good afternoon, everyone, and I hope you are all enjoying CIAT so far. I'm excited today to present the findings from CareDx's recent Admiral study. This landmark study not only enhances our understanding of donor-derived cell-free DNA, but it sets the stage for new possibilities in areas of early graft injury and immunomodulation. As transplant physicians, our current measurements of allograft rejection are delayed and outdated. Waiting for clinical presentations such as eGFR decline, proteinuria, DSA formation, and rising serum creatinine allow for a significant amount of inflammation and damage to have already occurred at the level of the allograft. We now know that our so-called tried and true historic marker, serum creatinine, is nonspecific and can fluctuate for a number of reasons, both transiently and chronically. Creatinine doesn't always provide sufficient information to guide intervention and is an insufficient marker for graft injury. Additionally, subclinical measures like DSA, as well as obtaining biopsies, often occur once inflammation is already intermediate and pose their own issues with complications and cost. This then begs the question, what could be a better determinant of graft function and provide sufficient information long before the onset of allograft injury? We now know donor-derived cell-free DNA and gene expression profiling are these key earlier markers. With AlloSure, we see that if we unlock the molecular window, we have a key view into a leading marker of injury or inflammation. The strategy in trying to mitigate risk and improve outcomes is therefore to identify and utilize these earlier indicators of injury and inflammation, thus allowing for the earliest possible intervention. As with all innovation, there is an evolution over time. AlloSure Kidney has been around for a few years with proven utility in multiple studies. Today, what I will be sharing with you is some insights from the Admiral study, which looked at longitudinal outcomes with donor-derived cell-free DNA. From the DART study in 2017, we know a score of 1% or more identifies active rejection and signals active injury. We also learned that we have a peace of mind score of AlloSures less than 0.21%. That yields a high negative predictive value for active rejection, and this is where the majority of the stable, healthy kidney allografts land. Through data from Bromberg and colleagues, we learned that the relative change value, or RCV, linked to biological variation is less than 61%. Thus, changes greater than 61% are considered abnormal or pathological and may warrant intensification of monitoring. The RADAR study in 2020 demonstrated how AlloSure can help differentiate ambiguous rejection and that subjects with a score of 0.5% or above demonstrated a significantly higher risk for eGFR decline, recurrent rejection, and de novo DSA development. Now, in 2021, we pivot to Admiral, where we looked at longitudinal outcomes in the surveillance setting in an effort to understand or correlate the relationships between AlloSure and DSA formation, changes in eGFR, and other types of injuries such as proteinuria, infection, AKI, and DGF. We also looked again at RCV in an effort to identify what change is clinically meaningful or linked to injury. This is the logical next step to applying AlloSure to routine practice. Admiral stands for Assessing Donor-Derived Cell-Free DNA Monitoring Insights of Renal Allografts with Longitudinal Surveillance. It was recently published in January in Kidney International. The 7 centers on this slide participated in the investigation and were some of the early adopters of AlloSure. This landmark study was a large multi-center independent validation of the DART findings. A total of 1,092 kidney transplant recipients were enrolled, with almost 4,000 AlloSure results. Centers were using surveillance protocol or center-specific surveillance protocols. Overall, there was a median value of 6 AlloSure visits per patient, and patients were monitored for up to 3 years. A total of 219 paired biopsies were obtained as part of the study. Of the 219 biopsies, 109 were performed biopsies for surveillance, while 110 were paired biopsies for cause. Within the surveillance set, there were 35 confirmed cases of ABMR and 10 confirmed cases of TCMR. Within the for cause set, there were 110 paired kidney biopsies performed for clinical indications, including elevated serum creatinine, proteinuria, and de novo DSA. There were 40 ABMR episodes and 28 TCMR episodes within this cohort. It's important to note that paired biopsies were considered biopsies performed within 30 days of AlloSure results, and all biopsy reports were centrally reviewed and rescored based on Banff 2019 criteria. Mixed rejections included as ABMR and borderline rejections were excluded from the study. In addition to primary rejection outcomes, the investigators set out to determine if there were correlations between elevated AlloSure values and the surrogate hard outcomes of de novo DSA development, eGFR decline, and allograft injury. Within the de novo DSA cohort, there were 961 patients with paired donor-derived cell-free DNA and DNA testing. Patients did not have pre-existing DSA. Of these patients, de novo DSA were found in 44 patients, or 4.6%. All subjects enrolled had EGFR calculations and were included in determining the association of donor-derived cell-free DNA elevation and EGFR progression. Of these patients, 113 had biopsies with confirmed rejection. And finally, in the cohort correlating donor-derived cell-free DNA elevations and graft injury, 467 patients were found to have allograft injury, and another 180 patients displayed no evidence of kidney allograft injury and were grouped in the quiescent category. Overall, patient demographics within the study cohort were consistent with national UNOS data. Of note, African American populations were better represented with Admiral, with 28% versus 24%. In addition, the subjects in Admiral were transplanted primarily from deceased donor kidneys, 94% versus 68%, and only 8% of the patients in Admiral were retransplant recipients versus 13% nationally. Switching gears to the findings of the Admiral study, we begin to see that AlloSure can discriminate rejection in both surveillance and for-cause settings. AlloSure demonstrated a 62% relative improvement over serum creatinine to discriminate all rejections. The resulting AUC for the ROC curve was 0.8 for AlloSure compared to 0.49 with creatinine. Thus, we are seeing again that in discriminating rejection versus no rejection, our historical marker creatinine is similar to that of flipping a coin. As we dissect the data even further, we find that Admiral independently confirmed the findings from what we learned in the 2017 DART study. AlloSure was again shown here to be superior to serum creatinine in detecting biopsy-confirmed rejection from no rejection. Looking at median values during no rejection, we see these are 0.23%, and similar to the peace of mind score of 0.21% identified in the DART study. Conversely, during rejection, the median AlloSure rose significantly to 1.6%. On the other hand, there was no statistically significant difference in median serum creatinine values during no rejection or rejection, with values of 1.38 and 1.57 respectively. Not only do we see superiority to serum creatinine, but we also see confirmation that AlloSure can discriminate for each subtype of rejection in Admiral. Importantly, the median AlloSure seen in Admiral for confirmed TCMR is 0.7%, which was significantly higher compared to no rejection. The same held true for the comparison median values in ABMR of 1.8% compared to no rejection. If we refer back to Dr. Steit's previous work on the RADAR paper, this median of 0.7 is importantly above the new lower threshold of 0.5%. Recall that RADAR demonstrated how AlloSure can help differentiate ambiguous rejection and that subjects with a score of 0.5% or above demonstrate a significantly higher risk of EGFR decline, recurrent rejection, and de novo DSA development. Another exciting signal we are seeing from Admiral is that AlloSure can be used as a marker of quiescence. The exploratory analysis looked at the idea of immune quiescence by asking what the AlloSure level was in stable patients in whom any potentially confounding injurious event could be excluded. The injury category defined here is quite broad, including tacrolimus levels of less than 4 or greater than 12, BK viremia, de novo DSA positivity, urinary tract infection, proteinuria, allograft rejection, or recurrent focal segmental glomerulosclerosis. By defining injury very broadly, we're more confident that the patients included in the immunoquiescent category are truly immunoquiescent. This now opens the door for possible immunomodulation of immunosuppression based on the study findings. There are 180 patients considered quiescent with a median AlloSure of 0.21. This again lines up with the DART paper and validates using that as a peace of mind score outside of the DART cohort. 467 patients were found to have injury with a median AlloSure during injury of 0.51%. This demonstrates that using a threshold of 1% is now short-sighted. It displays how AlloSure is not a binary yes or no variable for rejection alone. Rather, AlloSure is likely more beneficial across a continuum of care. The Admiral data also added to our understanding of the association between high AlloSure values and de novo DSA formation. All patients started without identified DSA in this study analysis. An AlloSure value greater than 0.5% was associated with a threefold risk of subsequent de novo DSA. In addition, every 1% increase in AlloSure score was associated with a 20% increase in de novo DSA risk. The key here is to note the lead time to elevation. These elevations in AlloSure occurred a median of 91 days before the de novo DSA detection. So it makes one stop to think, what could we do with those extra 90 days? Could we possibly intervene by increasing monitoring or optimizing therapy? Could these interventions mitigate the hard outcome that would have resulted? The final outcome assessment was in evaluating eGFR. Specifically analyzed was how AlloSure provides information on long-term outcomes by identifying patients at risk for eGFR decline. Elevations in donor-derived cell-free DNA greater than or equal to 0.5% were associated with significant eGFR decline between 12 to 36 months. The correlation coefficient noted was negative 0.84. Furthermore, persistently elevated donor-derived cell-free DNA, noted as greater than 1 result with a value of greater than or equal to 0.5%, equated to a nearly twofold increase in rise of decline in eGFR over 3 years. Lastly, we know as with DSA and serum creatinine, there isn't one threshold or cutoff that can be applied to each patient. Rather, following the trend or delta change can provide more insight into graft function or dysfunction. AlloSure is the only donor-derived cell-free DNA with validated longitudinal management using relative change values. Previous data from Bromberg showed that a relative change value over 61% exceeds biological variation. Now, from Admiral, we are learning an increase of 149% is highly indicative of graft injury. In summation, the Admiral study provides some key takeaways. AlloSure is the only donor-derived cell-free DNA clinically validated for surveillance in a large multi-center study. Importantly, we see a 62% improvement over serum creatinine in identifying rejection. AlloSure is the only donor-derived cell-free DNA with validated management using relative change values. And Admiral shows that there are opportunities to act with earlier signals of graft injury, rejection, and future prediction of de novo DSA. These last findings leave us wondering what the future of cell-free DNA will be across the continuum of post-transplant care. And especially, will immunomodulation be next on the horizon for our transplant recipients? Thank you.
Dr. Desai, thank you so much. What incredible findings with Admiral. My personal favorite is the DSA finding. Can you imagine what a difference an extra 100 days can make for our patients? We are super excited about this. Well, now to pass it over to Dr. Hararian, who will share why one test is not the answer, multimodality is.
Hello. Our transplant patients experience a variety of stressors during their post-transplant journey. Some are highly sensitized, some had prior transplants that increase the risk of their immunologic events and worse graft outcomes. They need to be on immunosuppression, and both under and over immunosuppression leads to their related complications. Many of them require hospitalizations as a result of the issues that come up from their immunosuppression. And the cumulative injuries to the graft lead to decrease in the GFR, various degrees of proteinuria, and in the tissue level, progressive fibrosis of the kidney. And that leads to graft failure and return to dialysis or need for transplantation. Over time, we have added new tools to our toolbox to monitor the health of the graft and the health of the patient. Initially, we had serum creatinine and urine protein and drug levels to help us to manage these patients to try to optimize their drug regimen. Then we added BK virus screening as a surrogate for over-immunosuppression. And more recently, monitoring DSA to identify under-immunosuppression. Even in combination, all these tools lack the adequate sensitivity or specificity to help us to manage our patients properly. We need to move to an era of multimodal testing using more sensitive and specific tools to assess the different injuries to the organ from different angles. I have to congratulate CareDx to be a pioneer in aligning itself with this new paradigm by offering a variety of new tools that help us to manage the care of transplant patients. Potential to become a surrogate endpoint in clinical trials. AlloMap provides the gene expression profile in peripheral blood to assess for rejection in the organ, and you will hear about it more in the next section. And in the pipeline, we are waiting for validation of UroMap that looks at RNA signature in the urine developed by the Cornell group to help us diagnose acute cellular rejection. HistoMap, using the nanostring technology, provides information about the gene expression at the tissue level, with the difference that the tissue can be fixed in the paraffin block, in contrast to the current method that we need fresh tissue fixed in RNA later. And the AlloID can increase the diagnostic yield by using metagenomics in addition to conventional microbiologic studies to improve the diagnosis of different infections. And we have to wait for validation of all these novel tests to be added to our toolbox to better take care of our patients, to ensure the longevity of the organ and health of the recipient. In the next section, Dr. Rao will give you specific examples of multimodal testing with the novel tests. Thank you.
Thank you, Dr. Hararian. There's a lot to be done in the field to ensure a comprehensive view of allograft health. Well, now over to Dr. Singh, who will highlight the validation of AlloMap Kidney and combination of it with AlloSure.
Good afternoon, everyone. Thanks to CareDx for giving me this opportunity to present at the CEOT meeting. I am a transplant nephrologist and a medical director for kidney and pancreas transplant at Willis-Knighton Medical Center in Shreveport, Louisiana. I'm presenting this study because we have participated in the OKRA trial and we had a lot of experience with the CareDx and the kidney care while working on the study. So the topic of my presentation today is kidney care improved precision with multi-modality. Kidney care, as we know, is a multi-modality screening tool which consists of AlloSure, AlloMap, and iBox for screening patients with kidney transplant recipients. AlloSure, we already know, has been in use since 2015 when it first got approval by CMS for clinical use in transplant recipients. It measures donor-derived cell-free DNA, and which in turn reflects allograft injury. AlloMap is a peripheral blood gene expression assay. It's a 5-gene expression panel, which measures either immune quiescence or immune activation in kidney allograft recipients. And it can actually measure not only uh, it can only not only measure the patients' immune quiescence in stable allograft patients, but also patients who are undergoing AKI and might have underlying rejection. And IPOX is a composite score which is based on clinical inputs and provide prognosis about graft survival at 3, 5, 7, and 10 years. So AlloMap kidney, as I mentioned earlier, it measures immune activity in kidney transplant recipients and can tell us about either immune quiescence or immune activation in patients who either have stable allograft function or might have unstable function and are experiencing AKI. AlloMap kidney has been under development for last couple of years, but AlloMap heart has been standard of care in the heart transplantation world for more than 10 years. The AlloMap heart uh, uses a 10 gene expression panel, whereas AlloMap kidney is more specific to the kidney and only uses 5 gene expression signal. The kidney care, which consists of AlloSure kidney and AlloMap, uh, has has the advantage of providing more comprehensive assessment of kidney health. So AlloSure kidney, as we know, which has been in use for a long time, can detect graft injury at 0.21% threshold with 95% negative predictive value. Uh, and in patients who are DSA positive and are suspected to have ABMR, the positive predictive value for ABMR is 89%. And AlloSure is the only cell-free DNA which can discriminate and replace rejections. Allobac kidney, when used in conjunction with AlloSure, is supposed to provide more value to the kidney care. Uh, and, uh, and as we already know, AlloMap heart is already approved for use in the heart transplantation. There's a hope that AlloMap kidney will also get FDA approval because it has the same gene expression panel for rejection as it is for the heart. So coming to the real world data about kidney care, the kidney care has been clinically validated in a multi-center study. This was a large study across different transplant centers in the US with the 15 leading US transplant centers which participated in the study. Uh, Most of the centers were in the Northeast, some in the Midwest, South, as well as at the East Coast. The patients who were enrolled in the study uh, had had demographics similar to the patients with renal demographics. The study had two validation sets. The primary validation set consisted of 98 quiescence and 18 rejection samples, and the secondary validation set had 8 quiescence samples and 11 rejection samples. So Alumab kidney has been validated in a training set from the samples which were taken from DART study. The training set consisted of 38% samples. These were all from healthy, stable transplant patients with the allosure value less than 1%. And then the training set also consisted of 18 rejection samples. 7 of these patients had T-cell rejection, 8 had ABMR, and 3 had mixed rejection. The primary validation set was later expanded to finally consist of 98% samples from 22 healthy, stable transplant recipients, 29 patients who were stable had no rejection episodes, and these were protocol samples, and 47 patients had no rejection. Then there were 18 rejection samples with 7 PCMR, 10 ABMR, and 1 rejection, same as for the training cohort. The Alva PD was later validated in an external validation cohort, which had 8 quiescent samples with no rejection and 11 rejection samples with 7 PCMR, 2 ABMR, and 2 mixed rejections. So what we have learned from our experience from all this from these studies is that not all injuries are the same. AlloMap kidney and AlloSure kidney, they pick up different signals, and these are independent from each other, which tell us, which give us a more comprehensive picture about the kidney health. So these independent signals are able to tell us what kind of rejection patient is undergoing, whether it is ABMR or TCMR, or if there is no rejection and there is immune quiescence. So as you can see in this figure, if AlloSure level is more than 1, that's where your ABMR is most of the time. Then you have an intermediate range of AlloSure between 0.5 to 1%, where you're going to see some TCMR, ABMR, and there will be some immune quiescence at that level. If the level is between 0.1 and 0.5%, you will see predominantly patients with immune quiescence. And for AlloMap kidney, if the level is above 10, that's where you start seeing most of the rejections. So these independent signals, which are picked up from AlloMap kidney and AlloSure, can tell you about allograft health, both rejection as well as immune quiescence. In contrast to using AlloSure or AlloMap alone, Kidney Care, which is a combination of AlloMap and AlloSure, Kidney Care is able to provide improved ability to discriminate rejection from quiescence. If you look at this figure, the area under curve for Kidney Care is 0.894, which is significantly better with p-value of 0.005 compared to AUC for AlloSure, which is 0.85, and AUC for AlloMap, which is 0.768. So Kidney Care is able to provide better rejection discrimination from patients who have immune quiescence compared to using AlloMap or AlloSure alone. In conclusion, Kidney Care provides improved precision with this multimodality approach. AlloMap kidney and AlloSure kidney contribute independent signals and inform on different aspects of allograft rejection. Multimodality tools like Kidney Care provide a more comprehensive assessment of allograft health in kidney transplant recipients. Kidney Care was clinically validated in a large multi-center study, and we have faith in the data with a lot of centers participating in the study. AlloSure and AlloMap kidney, when used together as Kidney Care, provides a more accurate assessment of allograft health, which we saw earlier with AUC of 0.89. Thank you.
Dr. Singh, thank you so much. Great findings from the validation and super excited where multimodality will take us. Now over to the cardiothoracic side of things above the diaphragm, where Dr. Deborah Levine will be sharing a bit about lung care and clinical utility of biomarkers in lung transplant.
Good afternoon, and I'd like to thank you all for joining, and thank you to CareDx for inviting me to speak today. We're going to talk now a little bit about lung, and I want to talk about the lung care platform and the ALAMO trial. Chronic lung allograft dysfunction, or CLAD, is the main etiology of morbidity and mortality at least 1 year post-transplant. And CLAD has many risk factors, including both immune and non-immune risk factors. Non-immune, including infection, as well as aspiration and reflux, which can cause injury leading to associations with CLAD. And then, of course, immune risk factors, including all types of acute rejection, whether it be acute cellular or antibody-mediated rejection, as well as antibodies, whether they're HLA or non-HLA antibodies, have been associated with the injury that can lead to the association with CLAD. So as you've seen in the prior slides in kidney and heart, we know there's a large body of evidence adjudicating the use of donor-derived cell-free DNA in terms of the association with injury and rejection. And this slide really shows us that there has been an exponential increase in the numbers of published publications, abstracts, and single and multi-center trials looking at donor-derived cell-free DNA in lung transplantation. Most recently, the use of AlloSure or donor-derived cell-free DNA has been looked at in a 4-center trial that was born out of the pandemic. During that time, we know we had to use a lot of non-invasive monitoring because bronchoscopy, biopsies, and even in-person visits were difficult and challenging during the pandemic. This study, again, was 4 centers, Inova, University of Maryland, Johns Hopkins, and San Antonio, really looking at a non-invasive monitoring platform for rejection or infection with AlloSure in conjunction with home-based spirometry, remote monitoring with remote phlebotomy, and symptomology. The primary outcome of this study was looking at the acute lung allograft dysfunction, which really included ACR, AMR, or infection, and that could be with or without the decline in FEV1. The study was called donor-derived cell-free DNA as a composite marker of acute lung allograft dysfunction, or ALAD, in clinical care. During the study, the AlloSure was used during surveillance monitoring at every month during the first year and every 3 months then after 1 year. The threshold levels used during surveillance monitoring were if the level was less than 0.5%, no further evaluation was conducted. Just continued on with that surveillance monitoring that we just talked about. If the patient was asymptomatic and the AlloSure was between 0.5 and 1%, those patients would undergo a recheck within 1 to 2 weeks. If that level became greater than 1%, those patients would proceed with bronchoscopy. If the AlloSure was greater than 1%, then all patients would undergo bronchoscopy, DSA, and spirometry performed in clinic. And again, if the patient were symptomatic or there was a big drop in FEV1 or symptoms, then the patient would undergo bronch and AlloSure at the same time. That was part of the protocol. So what were the results? Well, in 37 patients who did develop ALAD, or acute lung allograft dysfunction, those patients had a median level of 1.7%. And this was compared and statistically significant to those patients who were stable, and those were 0.35% in those patients. And you can see this in the graph to the right. Even more interestingly, is that the sensitivity was about 74% of patients who had a level of equal or greater to 1%, but even higher was the specificity of almost 88%. And I think the most important thing for us as clinicians, when you're looking at a surveillance and a monitoring and a kind of a risk stratification type of protocol, the non-predictive value was 96.5%. So this is a study that really demonstrated the clinical utility of how we can use AlloSure Lung in surveillance and monitoring post-transplant. And this was really the first kind of real-world multi-center with 4 centers looking at this during the pandemic. Again, this was a perfect time to look at it because surveillance monitoring during this time really was benefited by having a non-invasive type of protocol. So in results, the expected number of bronchoscopies or surveillance bronchoscopies that would have been done in a normal non-pandemic, kind of limited type of monitoring would have been 277 surveillance bronchs during that period of time. What we found was that only 77 bronchoscopies were done during that schedule because of that. So that was a very significant decrease in the number of biopsies being done for surveillance. Dr. Polly Shaw from Johns Hopkins looked at a subset of patients, and what they looked at was what did donor-derived cell-free DNA combined with home spirometry compare to if you did bronchoscopy and clinic-based PFTs? Well, they found that there was really comparable medium-term allograft outcomes, which is really important because, again, hopefully adding more fuel to the fire that we can look at things non-invasively in the future. I'd like to go to the second part of the talk right now and really talk about lung care. Now, this is a kind of all-over platform that includes donor-derived cell-free DNA and lung AlloSure, but also includes many other platforms that are important and will be important in future monitoring and surveillance in lung transplant patients. It includes peripheral-based blood biomarkers, which looks at graft injury, obviously with the AlloSure, AlloMap looking at immune activity, AlloHeme looking at tolerance, and again, looking at something that's very important in lung transplant as opposed to kidney and heart, but looking at the evaluation of any type of microbiologic assessment for infections. In the future, also looking at tissue biomarkers and artificial intelligence with both HistoMap and AlloView is an important and additive portion of lung care. The way we can look at lung care is in a new study that's been initiated in multiple centers throughout the country called ALAMO. And the primary objective in ALAMO is to look at the event-free survival at 3 years. This is really looking at the utilization of how we can use lung care to not only improve survival, but other clinical outcomes. The primary outcome is both clad-free and severe infection-free 3-year survival compared to a control group. The secondary outcomes are looking at how many bronchoscopies need to be done, hospitalizations, ICU hospitalization rate, intubation, mechanical ventilation, infection, and then rejection. So the study includes 500 control patients compared to 1,000 case patients. And during that platform for the 1,000 case patients, patients would undergo phlebotomy, looking at lung care drawn at both clinic visits, but also during protocol and for-cause bronchoscopies with biopsy. Again, the primary endpoints is clad-free and severe infection-free survival and multiple survival secondary endpoint, as we discussed. It also will help give us a platform to really validate some of the other lung care strategic platforms. So we are going to be learning a lot about all of these things in the next 3 years during Alamo and beyond. And we'll be excited to see the results of these and even, interim results coming up, hopefully within the year. So thank you so much and have a great CIAT and enjoy the rest of the meeting. Thank you so much. Bye-bye.
Well, thank you so much, Dr. Levine, for that excellent talk. And thank you, Dr. Desai, Dr. Hararian, for your excellent talks as well. I just want to quickly introduce my colleague, Dr. Jeff Rogers. So Dr. Jeff Rogers is the head of our medical science liaison team over at CareDx. And he's a transplant surgeon, kidney and pancreas surgeon. And prior to joining CareDx, he was at Wake Forest, where he was also an associate dean for medical education. Glad to have you on the panel, Dr. Rogers. For the audience, please use the Q&A section for putting in any questions for the speakers. We have about 15 minutes for Q&A, so we'll try to take as many questions as we can. Dr. Desai, if I can just start with one question of my own. So you talked about Admiral findings, and I don't know about you, but my personal favorite is the lead time that AlloSure can give over detection of de novo DSA. Can you talk a bit about, in your clinical practice for your patients, what kind of difference can that lead time make?
So that for us in clinical practice can make a difference in maybe even preventing the DSA or de novo DSA development, right? Because if we begin to see that the AlloSure levels are elevated, we can begin to adjust the immunosuppression to maybe more broadly cover the individual patient so that we don't see any de novo DSA development down the road as we begin to kind of monitor and parallel and check them. So I thought that that was a very interesting finding because that begs the question again, what can I do now to prevent the future determined outcome? And so that's how I would manage it. Then I would begin to more closely monitor the patient and see if I could adjust things to prevent that development down the road.
Excellent. Thank you. Yeah, we often complain about, it's to our patients that, maybe it's too late, maybe if we cannot do anything. So it's good to see tools now that we have where we don't have to complain about that.
exactly.
Dr. Hararian, if I can ask you a question about multimodality. So you talked
Sure.
about, the role multimodality has to play in future monitoring of our transplant patients. Uh, can you talk a little bit about how you see them coming together outside of just the diagnosis of rejection? I mean, we have seen with the kidney care that the two tests together perform really, really well with the AUC of zero point 0.9 in diagnosis of rejection. But beyond that, how can the two tests complement each other with their orthogonal signals to improve patient care?
So currently, we don't have any reliable biomarker that we could use alone to help us to identify different types of injury in the organ, either alloimmune response causing injury or infections like BK nephropathy that is causing the injury to the kidney, or other infectious disease processes. And in terms of the alloimmune response, what kind of alloimmune response is leading to the ongoing rejection or injury to the kidney. So we need to put different biomarkers that give us kind of different sorts of information in regarding the type of injury that is happening in the kidney, and analyze them together to give us a better understanding of what really is going on in the organ. So we can start with preventive
Um, Dr. Harian, looks like we're having a little bit of an issue with your internet, maybe.
measures.
Yeah, we can hear you better now. I'll come back to you in a second while we wait for your internet to stabilize. Okay, let's go to the audience question. So, one question is for Dr. Desai: what was the testing schedule used in Admiral study that determined surveillance?
So there was either the center-based testing schedule, so not all the centers had to follow the Admiral study protocol. And so that could have been whatever the center had decided. The Admiral study itself was, I think, at 1 month, 3 months, and then, or maybe monthly. Nikhil, you would have to remind me. But there was a set protocol for Admiral, but not all centers followed that. So I think there was
Yeah.
discrepancies in which institution was following which model.
Right. So the testing schedule was center specific, just like how AlloSure is generally used by
Right.
physicians. Uh, Centers were following either the ARS protocol, which is month 1, 2, 3, 4, 6, and quarterly thereafter, or they had their own schedule. On an average, a patient had about 6 AlloSures per
Right.
patient in the Admiral study. Yeah. Dr. Levine, the next question is for you. How were the thresholds for AlloSure Lung determined? And how do I get involved in Alamo?
Oh, great questions. Great questions. I think number one is easy. I think we can have someone from the CareDx team contact you. Maybe if you, or you could email me and I can get your name over to them. It's great. The study is, a solid study with multiple centers. That would be great to have you involved. I'm not sure who wrote that, but we'd be happy to have you involved. I think when you start looking at lung, obviously, as in most cases, we follow, kidney, heart, when we're looking at things in terms of assessment as well as uh, general treatment. So I think when you look at where the thresholds were in other organs prior to looking at the lung, I think there is some general kind of guidelines or kind of a bench of where it may be. And then looking at the studies, whether it be graft study, the alarm trial, which was done with 4 centers, looking at these and kind of adjudicating where these 0.5, 0.5 to 1, and 1 thresholds were adjudicated is really from data plus experience from other organs. But and I'm not sure, I can't see where that is, but maybe we could help whoever is asking this to help us get them
Sure.
involved
Yeah,
to.
I'm sure there is a way for us to reach the people on the Q&A section. Dr. Levine, if I can, like, as nephrologists, we often complain about, poor long-term outcomes, but I can't imagine what you and your patients go through. So I would think that there's probably a sense of urgency in terms of implementing these molecular tools. I mean, we have seen huge interest from pulmonologists all over the country trying to use these tools in their patients. But can you talk about like how urgent is the need in lung transplant?
Oh, I think it's great, and I think you're hearing it from all of us because it's true. I mean, when you look at graft dysfunction, and when we just had a really nice, great, absolutely great session just right before this, and I'm hoping everybody heard that. And if they didn't, it will be online from CIOT, the lung allograft section. And I think there's obviously CLAD is our um, primary survival obstacle in lung transplants after 1 year, and finding risk assessment and also biomarkers that can help us with early identification is quite important. I think, as you said, important maybe more than in any other organ, with our survival times only being about 6.5 years at 5. So I think 50% survival at 5 years. So I think it is urgent, and the idea that we can look at a marker that can identify early injury, whether it be infection, acute rejection, or anything leading to CLAD, is important. And I think that's what most of the studies are, either single center and now Alamo and other, smaller multi-center trials are looking at how we can use this, number one, along with our other risk assessment tools, but also maybe in time instead of some of the non-invasive. And I think we have, I think that's what our goal would be. And I think, again, maybe more important in our organ because of the severity of CLAD.
Excellent. Thank you. Thank you. Looks like Dr. Herrerian is back.
Yes.
Uh,
Sorry, I don't know what technical problem happens
no, no,
today.
no. It's all good. Uh, Dr. Rogers, don't want to leave you alone. So tell me about where do you think AlloSure can lead us? AlloSure and AlloMap kidney care. Where do you think it can lead us? I mean, we obviously have achieved great diagnostic accuracy, but what's next? How do we translate this into making sure our patients are optimally immunosuppressed, making sure that their long-term outcomes actually improve?
Yeah, I think, a lot of this boils down to how quickly we can understand what's going on with a graft before we start to see changes in the typical things that we follow, like creatinine and proteinuria and DSA. So biomarkers are giving us an earlier insight into what's going on before irreversible damage occurs. And this mentioned opens the door to potentially intervening early and changing what we do so that we can change the trajectory of what will happen with a kidney over the short and over the long term. I think in general we have a tendency to over immunosuppress our patients. And so it's not just being able to identify rejection or injury early, but also the opportunity to identify quiescence, which may allow us to reduce immunosuppression. And that could obviously decrease the risk of malignancy and infection and other associated problems that we see from immunosuppression. And it may also allow us to decrease our reliance on nephrotoxic medication. So really, I think that the direction obviously for us is multi-modality, as was presented. We see benefits from different signals with AlloMap Kidney and with AlloSure. And I think the two combined give us more power in terms of understanding what's going on and being able to optimally manage our patients.
Thank you. Thank you so much. And as the only surgeon on this panel, do you think there's a possibility that these molecular tools, whether it's gene expression or donor-derived cell-free DNA, can help us optimize donors as well, or like provide therapies prior to transplant? Is there a possibility of that?
I think that's a great question, and it's something that I've actually given a lot of thought to. And my short answer is yes, I think it will. Obviously, there's all kinds of physiologic things going on with a brain dead donor. And so to have some, I guess, insight before we even transplant an organ as to what might be going on with that kidney could be tremendously valuable. So obviously something I guess I would call that still a gestational idea, but it's something I would like to see bear fruit for us in the future.
Thank you. There's one question for Dr. Singh. Unfortunately, he got stuck on the airplane. So let me try to answer that. The question is about how has the access to multiple scores with gene expression profile and donor-derived cell-free DNA shown to actually alter patient management decisions? So kidney AlloMap is part of OKRA study, and it's also now clinically validated. And we also published we also got CLIA testing done, but it's not commercially available yet. So that's why it's hard to answer that question. But from the data, we can tell that the two tests, AlloSure and AlloMap, they provide complementary signals. So it's easy to see how they will alter patient management decisions. I think we have time for just one more question. So, Dr. Desai, do you see AlloSure or donor-derived cell-free DNA being implemented as part of histological diagnosis? I think the question is probably referring to something like the RADAR study, where AlloSure is able to differentiate low-grade TCMR and borderline rejection, which do well versus the ones that don't.
I guess, meaning you would use the AlloSure to begin to make treatment without getting pathologic
No, I think
findings? Is
the
that?
question is about adding it to the histological diagnosis. So how can it, I would say, probably like augment histological diagnosis?
So I think if we were looking at the diagnosis and we were not able to determine if this is a TCMR or a borderline rejection, then we may use the AlloSure in conjunction. So we do that quite often in clinical practice, where we may have an AlloSure that was elevated, and then we want to follow up, but we'll get an AlloSure at the same time as a pathologic biopsy that we do for the patient to help determine kind of the gradient and the differential change, and decide then if the pathology is borderline versus actual
Right.
T cell rejection, whether we should move forward with treatment or not. So we like to get both in conjunction together in real time as often as we can, so that we could see what the changes are.
Would you think it'll be
I wonder if
useful
that's
to?
answering the question.
No. I mean, I think it does.
Okay.
Would you think it'll be useful to consider adding it to, let's say, the BAM score, because they can be somewhat subjective. So will it be productive to add it at least in certain categories, such as TCMR, as you mentioned?
Maybe down the road. I mean, isn't that the ideal that we want from our cell-free DNA findings, is that ultimately we could use that test result to be able to say that this is going to be a BAMF1A or this is going to be a borderline sort of finding. But I think that's going to take some time for us to determine, right? And that would be ideal for me as a practitioner, because then you wouldn't have to do any invasive biopsy or actually look at the tissue. You could use the results and the scores to actually be able to modify your immunosuppression, whether there's quiescence because the level is nice and low, or whether you're seeing that the value is 5%, then 5% equates to a 2A. I would love to see that
Right.
as we move down the road, that we can actually use the data and the findings to forego a biopsy in the future and then be able to treat based on the result.
Great. I just want to end this Q&A with one question for all of you, including you, Dr. Rogers. So in 2022, what do you want to see happen with multimodality? What would you like to see? Where would you want it to go? I'll start with you, Jeff. Seems like,
Whenever I hear,
oh yeah, we can hear you now. Go ahead.
I'm sorry. So I'm having tech problems too. So, as we heard in Dr. Levine's presentation, it took a pandemic to really push them out of their comfort zone in terms of how they were doing surveillance in lung transplant recipients. And I think as physicians in general, we sometimes get very set in our ways and our protocols, and we don't go beyond that until we're forced to. And so I guess I'll answer your question with a question, and that is what kind of things should we be thinking about now that will push us out of our comfort to drive implementation of multimodality therapy or multimodality surveillance in our patients. And so I think that's really where we're going. We have really valuable tools now at our disposal, and I need to start to think creatively and outside the box about how we will implement these in our clinical practice, short of waiting for another variant to come along to push us out of our comfort zone again.
Yeah, makes sense. Dr. Harry, what gets you excited about kidney care in 2022, multimodality in 2022?
So I would like to see more studies to better define the how we could use this multimodality toolbox and also make the AlloMap commercially available.
Excellent. We share that goal at CareDx, I can tell you that. Dr. Desai?
I agree. I'd like to see more studies, be able to utilize that better in clinical practice, have everything a bit more easily accessible and validated. And I think that that would be huge because then you can implement it not only in the transplant clinical practice, but then hopefully also in the general nephrology clinical practice, or as you're bringing it out to our partners that then take our transplant patients and continue to care for them.
Dr. Levine, you'll have the last word.
No, I think all of the comments have been just right in the right direction. I think for lung, we're maybe a little bit farther behind, but that's okay. I think getting more data, and that's what we're doing with Alamo and multiple physician investigated studies to really figure out how to monitor, how to use it as a monitoring tool, a risk assessment tool, and maybe how to adjust treatment. And I think that's where we're at with lung, and I think we're all looking forward to knowing more. So thank you.
Excellent. All right. With that, we're going to close the session. Thank you so much to our speakers and, of course, our audience for attending the session and asking some great questions. Have a great one, everyone. Enjoy the rest of the CEOT conference.
Thank
Bye.
you.
Thank you.
Bye.
Bye-bye.
Bye.